Okay, let's now turn to the risk here in the United States. I mean, I think we can all agree that Africa's a mess, and this epidemic is a disaster, and it's getting worse. But let's talk about the United States. People are obviously concerned. Clearly you're concerned, I'm concerned, we're both in the healthcare field. People who live in or travel through Dallas and now Cleveland, as one of the two nurses that acquired Ebola from the Index case traveled to Cleveland by air and then back to Dallas. What are your expectations regarding the potential for an outbreak in the United States?
Based on the Dallas case and the travel to and from Cleveland, I think that's very flimsy until and unless they show someone actually came down as a result of that particular activity. I think it was enhanced by some arbitrary cutoff regarding fever at the airport. And it's my understanding that the nurse that traveled to Cleveland called the CDC herself 3 times, and they told her it was okay.
I heard the same reports you did, that she called the CDC and that her fever didn't make the cutoff on somebody's arbitrary list, and she was told it was okay to fly.
Which is amazing, considering the reports that seem to be blaming her for what she was doing. She did her due diligence, exactly.
Yeah. Once you're symptomatic and you are a known contact, if you will, you're at contact risk, you've been around Ebola, you've been treating someone with Ebola, your family member has had Ebola. How do you then make the diagnosis once there's a fever or any other symptom?
Like is true in many infectious diseases, and we are not orthopedists. In ortho, the patient tells you where to x-ray, right? And then it's broke and then they fix. In our particular field, they have what's called an index of suspicion. For Ebola in particular, that begins with a careful travel history. It doesn't even have to be a careful travel history. Have you been to Liberia, right? Nigeria,
right. Guinea,
Ivory Coast,
right. Okay,
so that's a basic question right there. If somebody were to come to an emergency department with 102 or 103 and looking sick, I just came from Africa, they may have come here to be treated.
But again, that's a presumptive diagnosis. And with that history, with those symptoms, you go ahead, you isolate them. But then how do you nail it? How do you make the diagnosis?
From my contact with the CDC, is my understanding that within 3 days of the onset of symptoms, a reverse transcriptase polymerase chain reaction, or RT-PCR, can be done to find the genetic material of the Ebola virus. At the same time, there are fairly reliable ELISA antibody tests which will show IgM and IgG antibodies.
So these are blood tests?
These are blood tests.
They're being done in Africa, they're being done here.
Yes, they are.
Pretty quick turnaround. I mean, I hear
it's a fairly fast
result
turnaround.
Within a few hours.
In the right hands. But again, these are biohazards which limit our ability to test and diagnose and treat because of the risk to the laboratory personnel. The blood tubes have to be plastic, so there isn't any breakage and cross-contamination that way.
And
there are a lot of
themselves.
issues. And the needles themselves.
Are lethal.
Yes, sir.
I mean, I read that depending on the route of infection, the lethality can be higher or lower, and that by injecting Ebola, i.e. a needle stick with a hollow core needle and with blood, that lethality rate can be as high as 90%. So it's clear that people have to be careful.
Sure, the size of the inoculum axiomatically does have something to do with that.